The Australian Gastroenterological Society has released their updated guidelines on the management of idiopathic gastroparesis. The problem is, these are a novel form of guidelines that are diverting from the international consensus on the diagnosis and treatment of idiopathic gastroparesis. Note, idiopathic means no known cause. As a disability advocate who is on life support for gastroparesis caused by a connective tissue disorder, I am extremely concerned about the wording presented in this framework. So we are going to be comparing the Australian guidelines to the most recent treatment guidelines released by the American College of Gastroenterology. And we are also going to be hearing from patients in Australia who have already been facing the effects. The entire intention around the Australian guidelines is to reclassify idiopathic gastroparesis as a sensory motor disorder on the spectrum with functional dyspepsia, which is reclassifying it from a motility disorder which has a physical cause, regardless of if that cause is known, idiopathic, and reclassifies it as a functional GI disorder, which relates to the gut-brain axis and is not actually a condition with a physical manifestation. When we look at it, this is how they are describing it as a sensory motor disorder, which makes sense and absolutely correlates with the international standard. This doesn't really deviate it from it with regards to what we know about idiopathic gastroparesis as of now. We know that there are known gastric arrhythmias that affect the potential for gastric emptying. We know that pyloric dysfunction can cause small intestinal dysmotility comorbid with gastroparesis. But the conversation immediately starts to shift to the high diagnostic overlap and comorbidities in idiopathic gastroparesis, like forms of disordered eating. Now, disordered eating and eating disorders, EDs, are not the same, but they are starting to associate them together. There is an inherent form of disordered eating in all gastroparesis patients because a lot of us are not able to eat a standard diet. Now, whether that goes from small particle to the most extreme being on TPN, the diet modification is the key principle in the treatment and management of gastroparesis that we know right now. What they're saying with this Venn diagram is that a significant portion of people with idiopathic gastroparesis fall into overlapping categories with eating disorders, psychosocial comorbidity, persistent pain, and that keyword functional gastroduodenal disorders. Now, are advocates arguing that this overlap doesn't exist for some patients? No. But when you get into the other position from the Australian guidelines that they present, it becomes problematic because they insist on not looking into other causes that may not be obvious on endoscopy of idiopathic gastroparesis, like connective tissue disorders or autonomic disorders and autoimmune diseases, which are all known causes of gastroparesis. They are known subtypes. They're just not as common as diabetic gastroparesis. We are going to get into their proposed statements, which are essentially summaries of the scientific language presented in their guidelines for lay people. I don't necessarily have a problem with them making statements that have a low quality of evidence because unfortunately gastroparesis and other forms of dysmotility just do not have the body of research behind them yet. What I do have an issue with is them changing their entire treatment guidelines for a subtype of gastroparesis based on a low quality of evidence. Getting into it, idiopathic gastroparesis is a sensory motor disorder. There is a substantial overlap with functional gastroduodenal disorders and eating disorders. So, Substantial overlap is very hard to determine because they are interchangeably using eating disorders, which are pathological diagnoses, with disordered eating, which is a changed pattern from a healthy or typical style of eating due to, and it can include eating disorders, but other medical conditions. So somebody who is eating mostly carbs and processed food because they cannot tolerate digesting high fiber foods like vegetables and fruits, which, is extremely common in the particularly idiopathic gastroparesis population because they are undertreated. This being a recommendation just does not address the root cause, and I hate using that term because it makes me sound crunchy, and I don't intend on that. I hope you guys get what I mean. It doesn't address the root cause of that behavior. It's not a form of eating disorder, it's disordered eating. And so it's low quality of evidence, strong recommendation. Statement 2, a comprehensive medical, surgical, and psychosocial history is needed, including psychological comorbidity and nutritional assessment. I like that. It is a consensus recommendation, so that means it is following an international consensus in the field of gastroenterology. Statement 3, co-assessment by a clinician specializing in eating disorders is recommended for all patients with disordered eating behavior due to the high comorbid prevalence of disordered eating and eating disorders. So then they differentiate themselves again, which just, I feel like if they want to put so much of a focus on eating disorders and disordered eating, they should have had more sources and evidence correlated to this recommendation from actual eating disorder specialists. And again, low quality of evidence, strong recommendation. The evidence that they do provide talks about how eating disorders, disorders of the gut brain, and delayed gastric emptying frequently coexist. Studies have shown 20 to 80%, which is a very wide reference range of patients with an eating disorder may have delayed gastric emptying. We know that eating disorders can cause delayed gastric emptying because the stomach is a muscle. You use it or you lose it. That doesn't mean that they don't now have a physical disability in their ability to eat. And up to 98% experience functional gastrointestinal symptoms. So that's more focusing on the people with eating disorders that may experience gastroparesis instead of the large amount of people that have idiopathic gastroparesis that are either undiagnosed with their cause of gastroparesis or do fall into this category but don't have an eating disorder. Disordered eating behavior may predate idiopathic gastroparesis or develop in an attempt to minimize the symptoms of idiopathic gastroparesis. This is why psychological care should not be the only focus. It should be a collaborative effort, which I don't think is emphasized enough in this paper. What I will give them credit for is the most common eating disorder in the gastroparesis population is avoidant restrictive food intake disorder. My root problem with this is making this all a psychological issue and delaying access to medical care because you're sending someone to psych is the reality for a lot of patients, as we're going to get into. Statement 6, honestly, I feel like collaborates with international consensus. There really should be a standardized low-fat egg-based meal or a validated variant because so many people cannot tolerate eggs, but the percentages that we have for gastric emptying are based on the nutrient makeup of eggs. When modifiable factors are present, a repeat gastric emptying study should be considered 3 to 12 months after an abnormal result, following optimization of all reversible factors to improve validity. Very low quality of evidence, conditional recommendation borderline endorsement. So that means they disagreed on this one, which both positions I kind of understand, because getting a repeat gastric emptying study does validate whether or not your treatments are working, but having a normal gastric emptying study on file can be harmful for patients, because you don't just suddenly not have gastroparesis, you have gastroparesis that is being managed with treatment. And then also, for patients who are not succeeding, it is a very uncomfortable test to repeat if they are not tolerating food. So, I don't know why they deferred in this, but personally, I completely agree with Statement 9. I feel that all patients with gastroparesis should get a nutritional assessment by a gastrointestinal dietitian. Access to a specialized dietitian anywhere in the world is difficult, but especially in Australia. When we get into their position on nutritional support, it starts off agreeing with the international consensus that oral nutritional therapies are going to be the best first-line intervention. However, when it gets into enteral feeds or tube feeds, they kind of are missing the point, and I don't know the rate of intervention for tube feeding in Australia versus other countries. However, their recommendation is nasogastric feeding is recommended over post-pyloric feeding, which means into the duodenum or jejunum, as gastric emptying correlates poorly with symptoms. The problem with that is gastroparesis is often comorbid with a form of malabsorption, and they even acknowledge in their guidelines that over 50% of gastroparesis patients have at least one macronutrient deficiency. That is both related to diet and malabsorption. And it is known that people with gastroparesis have reduced uptake of nutrients through the gut, and anecdotal evidence heavily suggests that things like medications have reduced uptake. Speaking personally, I don't uptake my medications well through my gut, so I am on the max dose of anything that I have to take gastrically. But my levothyroxine, for example, my thyroid medication that is crucial for treating my autoimmune disease, has a notably better uptake through my jejunum because I can crush it and take it through my J-tube. And that has completely put my Hashimoto's into remission, where my Hashimoto's was fluctuating for years when I had to take it orally. So again, their statement on nasogastric feeding has a low quality of evidence. The decision to initiate long-term enteral tube feeding should be made only with formal multidisciplinary team consultation. This is the general consensus. Long-term enteral tube feeding should be avoided where possible. I don't think that anyone disagrees with this. However, I do feel like this needs to be a patient-focused discussion where even though it has not been shown to consistently improve global symptoms, I disagree that it does not improve nutritional status. And they also agree that it has a low quality of evidence. However, it does carry increased risk of iatrogenic harm, which is harm caused by the intervention itself. That is an acknowledged risk, but however, is that risk greater than long-term malnutrition is on the body, and especially with the focus being on eating disorders? Even if somebody has an eating disorder that has caused gastroparesis, does that mean they should not get nutritional support as long as it is showing clinically manifested results? And then statement 14 also agrees with the general consensus that there isn't a lot of evidence supporting parenteral nutrition, which is IV nutrition, in gastroparesis, but cases requiring TPN are generally not gastroparesis in isolation, and I feel like that should be noted with the emphasis on intestinal dysmotility and failure, which are, when you have a presence of intestinal failure, gastroparesis is typically also present. I know that wouldn't be considered idiopathic gastroparesis, but then they have an entire list of different neuromodulators here in the paper that can be thrown at idiopathic gastroparesis just to see what sticks, whereas there are only a couple neuromodulators that have been shown any sort of clinical significance in the treatment of gastroparesis, and typically it is only, again, to treat the symptoms, like, can't remember the name of it right now, but ones that will increase appetite, and they're only given because that is a side effect of the medication. But just because you're eating more doesn't mean that you're not then throwing it up more. That might be nitpicky. It is only a conditional recommendation on their part, but they do have like a huge list here, and I would hesitate to just be like, okay, let's just start with amitriptyline and go down the list and see what sticks, because I know there are providers like that. I don't know if it's like legal in some provinces or is legal across the whole country, but they do talk about the use of cannabinoids, and how they do slow gastric emptying, but paradoxically may improve symptoms of gastroparesis, including satiation, which is your, like, how soon you feel full. But there's insufficient evidence to recommend their use, so they do have conditional recommendation, and typically that is for symptom management that is not responding to other things like antiemetics or neuromodulators and things like that to increase appetite and reduce nausea. And then I do like their last statement here: evidence-based psychological interventions for overlapping disorders such as gut-brain and persistent pain disorders should be provided early in the treatment of idiopathic gastroparesis. However, what pain relief are we talking about? Because a lot of patients that do suffer from gastroparesis do have it because they have a need for the use of opioids because they have a persistent pain disorder or a chronic pain condition. And they are often just encouraged to be taken off their medication, so it's very much a battle of one against the other. And I think if we're giving this recommendation, we need to have more of a multidisciplinary discussion about this issue. I don't know. And then, this is the last statement. There is insufficient evidence to recommend intrapyloric botulinum toxin injection. Speaking anecdotally from experience, that didn't work for me very well because it paralyzed my pylorus open and just made my intestinal dysmotility worse for 2 months, and then it went back to baseline. Surgical pyloroplasty, which is where they cut your pylorus open. Gastric electrical stimulation, which is the gastric stimulator. From the studies I've read, those have about a 50-50 efficacy or a 60-40 efficacy. Or GPOM, which is a more, not low intervention, but like, it's a different form of pyloroplasty, basically, in medically refractory idiopathic gastroparesis, specifically. These therapies should only be trialed following multidisciplinary team consensus. Conditional recommendation. I misspoke earlier. I am referencing the American Gastroenterology Association, I believe. You can pause to read their guidelines. These are the American guidelines as of 2025 for gastroenterologists across the country in the management of gastroparesis overall. So this isn't just the management of idiopathic gastroparesis. This includes diabetic gastroparesis, gastroparesis caused by connective tissue disorders, autoimmune disease, SMAS, things like that. And a lot of it is similar and focused on symptom management. In my opinion, the body of evidence presented and the specificity of recommendations here for medications is higher quality and more helpful than the Australian guidelines. And with these being available, I feel like they could have been provided and given for patients as an option. But what I think differs significantly and follows the international consensus is the multidisciplinary evaluation involving gastroenterologist, endocrinologist, and registered dietitian. So more medical focus and not psychological focus, but not ignoring the psychological focus. When the American guidelines talk about refractory gastroparesis, so that is gastroparesis that has not responded to standard first-line therapies. They are considered to have gastroparesis refractory to medical therapy if they have cardinal symptoms of gastroparesis as the predominant symptoms, in addition to evidence of delayed gastric emptying with no alternative explanation for the symptoms, and have failed at least 2 medical treatments, including prokinetic and antiemetic agents. In patients with gastroparesis refractory to medical therapy, it is important to ascertain the accuracy of the diagnosis and to evaluate for coexisting conditions that may be causing or contributing to the severity of the predominant symptoms. Whereas the Australian guidelines here suggest against routine testing for vascular compression symptoms, hypermobility spectrum disorders, which they're including hypermobile EDS in here, which they should be including Ehlers-Danlos syndrome as a whole, mast cell activation syndrome, autonomic dysfunction, small intestinal bacterial overgrowth, or SIBO, or microbial dysbiosis, which are all known causes of gastroparesis. They recommend investigation into all of these, even though there is evidence to support it. And this stance is the reason that I enjoy the specificity of the American guidelines from 2025, because those specialties would understand the relationship that these have with gastroparesis, despite them not being necessarily routine diagnoses. They are becoming more known diagnoses to even layman gastroenterologists, not just motility specialists, at least in the United States. And then the American stance on enteral nutrition is very firm now, which I appreciate. It is important to evaluate the nutritional status of patients with gastroparesis refractory to medical therapy and to provide nutritional support, preferably orally as tolerated by the patient, or if necessary, using enteral nutrition. Parenteral nutrition is rarely used as it carries risk of serious complications like infections and blood clots. But I do like that they use the term rarely, not recommended, because those are 2 different things. Dying isn't recommended either, especially dying of malnutrition in the year of our Lord 2026. This video is so long. I apologize. If you are still here, thank you for hanging in there. These are testimonies from people who are experiencing the repercussions of this right now as we speak. My primary gastroenterologist is one of the writers of this. I will die before I get help. I'm so scared. They are also saying feeding tubes should be used for a month at most and shouldn't be long-term, even in malnutrition. I've had a gastric emptying study showing moderate to severe gastroparesis, but my doctors are refusing to diagnose this and wrote excluded gastroparesis in my chart because of this and calling it functional dyspepsia, so I need hypnotherapy. We love adolescent medicine doctors. Yep, I read their whole guideline booklet. They legit say tube feeding is expensive and to avoid. It seems all about money and cost cutting. Yes, I was left literally unable to move from bed, unable to watch TV even. All I could do was listen to podcasts and sleep from November to January because my gastroneuromuscular disorder and gastroparesis was marked functional, and therefore I was being left to starve. I lost 40 kilograms in less than 6 months, lost so much cognitive function until eventually a doctor listened and found the neuromuscular cause, so I got an NJ feeding and soon a J tube placed. But it's crazy to think if it had only shown gastroparesis, I would likely not be here anymore. Happening to me at the moment, referring to an ED clinic when I cannot keep food down and extreme pains when eating, on H2 blockers and PPIs for GERD. I'm so underweight, I'm struggling to gain weight tracking calories, and I'm over 2,000 calories a day and trying so hard. I'm not purposely getting diarrhea and regurgitating my food up. It's not in my head. I'm going through this currently. I nearly died last year because they took out my feeding tube and left me without one for 7 months. I nearly died due to malnutrition. They put an NJ in for a few months. Now they are refusing to put a new one in. One of the gastros spearheading the new guidelines was my gastro for a while, and they were absolutely horrific. I had confirmed vascular compressions, MALS and SMAS, as well as diagnosed gastroparesis, EDS, etc., and the gastro told me I just needed hypnotherapy. There it is again. So many people I know have almost died under this gastro's care. They have the worst reviews and are making it so many people with gastroparesis are more likely to pass from malnutrition. Oh, do you want to know why? I bet it's because of the NDIS. They're running screaming from actual evidence because having a disability which doesn't respond to treatment means that people have to be supported. So from many different conditions, especially autism, because autism is getting the blame for the cost of this program, our Australian government is trying to put out so much that just straight up defies evidence. There's a massive inquiry right now into the bill that is saying people have to have tried every treatment option for their disability to count. So by saying that a condition is psychosocial, you can eliminate it from being supported. Because how do you attempt to treat a psychosocial digestive disorder? It's so they can deny supports. I'll eat my hat if this isn't it. Yes, I agree. As an Australian who was left by multiple gastroenterologists, including a well-known researcher in this field, without treatment or care, I almost died. It was only when I was finally proven to have congenital SMAS and severe corkscrew deformity of my duodenum and jejunum, severe gastrotosis, and noted gastroparesis based on endoscopy and surgical findings. I was told for years I had an ED, left to decline to a point where I now have no potential for improving my gastroparesis or other issues it has caused. Our health system is killing us. I can definitely empathize with this, with my own experiences. I've been talking so long that my phone is dying. I hope this was as in-depth as you guys wanted. I'm very upset about this. I feel for everybody who shared their story with me. Thank you. And I'm just very scared of the ripple effects that it's going to have for some of you. I know that some of the healthcare in the UK is very similar to this. I know that in gastroenterology, it seems like, at least in motility disorders from my research and activism and volunteering with different organizations, gastroenterology and motility disorders in the US seems to be the most advanced field for the topic right now. And I would have hoped that these new guidelines would have influenced things positively internationally, and it just seems like they haven't. And I really want to hear your thoughts on this.